once again. Hello, everybody. It's a pleasure to be here. My name is Alexander Büsser, and I'm joined by Vanessa Kugler to represent a company called Exploris Health. So we are a diagnostic company based in Zurich, Switzerland. Our talk will focus on foundational models for coronary artery disease diagnosis. As a disclaimer, I'm a computational scientist by training, so my talk will have a very strong AI component, whereas Vanessa will afterwards take more of a system perspective to explain how these foundational models are improving care. So quickly to our motivation to work on this problem. So currently there is a CAD care gap. As most of you know, cardiovascular disease remains the global #1 killer. Most of them are caused by heart attacks. Our working hypothesis is that many of these heart attacks can be avoided if we're able to detect CAD earlier. CAD is a very complex disease that builds up over many years. So on a positive note, there's a long intervention timeline. So this gap leads notably to wrong patients being referred to unnecessary imaging or invasive procedures. At the same time, many asymptomatic patients don't receive the care at the right time. This all leads to unnecessary healthcare expenditures. Why do we not have good early detection tools out there? Well, biology is hard and simple equations are not very effective at modeling biological processes. We have it much easier in engineering, where physiological models work really well to, for instance, predict the successful launch of a new rocket. So researchers need better new tools to actually understand the disease biology. There is hope in a new technology which we term modern AI. These technologies have proven to solve very hard biological problems. Most notably, these models have been applied to predict how protein fold based on an amino acid sequence. As many definitions are around here, quickly for transparency, how do we define modern AI? So modern AI often has two components. In our case, there's a large model that learns in a self-supervised fashion or a self-supervised fashion, a broad abstraction of the biology, and we use this broad abstraction as input parameters into traditional models, which are trained on specific annotations in a supervised way, meaning we actually specifically predict whether a CAD is present or not. Now, we use these foundational models to build an in vitro diagnostic for CAD. In particular, we measure proteomic and metabolomic markers directly from the blood and then translate this diagnostic into clinically applicable risk stratas. As we design these diagnostics, we have two quality indicators. Like most diagnostics, we're interested in the area under the curve of the ROC, but not just the area is important to us. We're in particular interested in very steep inclination. So we want to have tests that have a very high sensitivity at a relatively low false positive rate. Additionally, we have some constraints, which is our diagnostic tools, our foundational models need to be highly replicable. So we test these models across different studies, different patient populations, and very important in CAD diagnosis, in different risk populations. Additionally, these models need to fit into clinical guidelines and have to be accessible. With accessible, we mean they have to be cost effective. They have to be used with routinely available clinical endpoints. and equally, they have to be usable by specialist physicians and general practitioners alike. So we're looking for a test that has very little intra-variability. Now, before we developed these foundational models, and I started my talk with that, right, that currently there is no effective single CED biomarker. So we screened over 120 available clinical markers to understand the discrimination ability for CAD. And as you can see, traditional risk factors such as high LDL have a very poor discrimination ability. So this motivated us to go for a multi-marker approach in the hope that multiple markers could explain a lot of the underlying variance. We currently have 3 models in the pipeline. So our first model was built and validated on 1 clinical study. So I should specify what we mean with internal validation is we use the clinical study to both build as well as validate the algorithm. And this model had achieved an AOC of 82%. Our model that is currently commercially available and regulatory approved is V2, that has been internally validated on 2 clinical studies and independently validated by 1. This model achieves an AOC of 87.8% and is stable across all studies. We have 1 more model that is currently under development, V3, that has been internally validated in 3 clinical studies, which has very desirable properties of an AOC of 91% with a sensitivity of 80% at a relatively or acceptable false positive rate. This algorithm is yet not regulatory approved, and we're looking for investigators to help us validate this algorithm externally. A quick note on data size. So this is not a sole predictor, right, number of samples. So this is a small comparison of the currently used clinical likelihood model recommended by the ESC 2024. So this is actually a very simple form of AI. It's been built on a logistic regression and trained on 41,000 patients. Our models, in turn, were trained with 1,360, respectively 1,645 patients, and achieve a notably higher discrimination ability. So much more important than size is the actual variance you capture through your clinical studies. So you're looking to have a very diverse population that enables these models to effectively learn and be good at the discrimination task. While you can see that we have notably improved the algorithm through additional patient counts, data remains very important to make meaningful progress on foundational models. There are many great consortiums out there. I want to note one in particular from one of our clinical advisors, Hans-Peter Brunner-LaRocca, the iCare for CVD program, that has managed to bring together many cohorts across Europe. So this cohort counts now in over 1 million patients, with many of these patients having multimodal data. The data is accessible through a secure network, so the data is decentralizedly stored to make sure that appropriate data safety requirements are met. I mentioned our algorithm MPAV2 is commercially available through our product Exploris. This is currently approved for patients with stable symptoms or risk factors suggested of chronic coronary syndrome. It is already being used by leading clinical institutions such as the University Hospital Basel in Maastricht and Bad Bevensen here in Germany. If you want to check it out, you can scan this code. This will give you directly access to our platform. And as mentioned, we're very grateful for any feedback that you have to our tool, or if you would like to further validate it through your own studies. so please do reach out. I'll leave you with 3 conclusions. So traditional risk factor screening remains insufficient for early and accurate CAD detection. Foundational models enable accurate CAD prediction even when training data is very limited. Access to larger and more diverse data sets is needed to unlock further progress gains from these models. With that, I'll hand over to Vanessa, who's going to talk about a recent publication we made on the German paradox. So please welcome Vanessa.
Thank you so much, Alexander. So yeah, I would like to show you in how far such AI-based multi-marker algorithms can now be used in order to make the CAD diagnostic more efficient and also improve patient care. I would like to show you a post-hoc analysis of our clinical data done by Rampis et al., which was published recently in September 2025. In that publication, Rampis speaks about the so-called German CAD paradox, which means that Germany has extremely high expenses for coronary angiography, while at the same time being at the very end regarding mortality because of cardiovascular diseases. So we do see high mortality while at the same time spending a lot of money for diagnosis. When we want to have a look at the root cause of that so-called German CAD paradox, this actually is happening at the very first initial assessment. The clinical likelihood has a huge impact of the further diagnostic process. And what we see so far in many markets, such as in Germany, is that true CAD cases, such as represented here by Sarah, who stands for all false negatives, are wrongly estimated to be healthy and are labeled as low risk and sent home, leading to late or missed diagnosis and high mortality. At the same time, we do have a high percentage of patients who are actually healthy, but they are mislabeled as being at high risks, represented here by Michael, who stands for all false positive cases, going through the whole diagnostic process, costing a lot of money. And as you can see here, the root cause of that problem actually starts right at the beginning, by a misestimation of the clinical likelihood. We do see here an overestimation of the clinical likelihood, while at the same time underestimating the clinical likelihood in the false negative cases. The ESC recommends to calculate the clinical likelihood in order to propose the right diagnostic pathway. So the idea is, if someone is labeled as low risk, we can defer further diagnostic. If someone is low to moderate risk, CT or functional testing is recommended, and moderate to high invasive coronary angiography could take place immediately. For that, the ESC recommended in the 2024 guidelines to use the RFCL score, which integrates age, sex, symptoms, and cardiovascular risk factors. In our post-hoc analysis of our own clinical data now, if we have a look at how MPA version 2, here labeled as Exploris, which is the commercial name, performs in comparison to the scores recommended by the ESC guidelines, we can see that the MPA version 2 showed the highest discriminative ability and also remains robust across different disease prevalence levels, while the ESC scores do not generalize across different prevalences. Another important key finding is having a look at the behavior of the negative predictive value. So the NPV represents the safety of excluding CAD, and clinically accepted it is to safely rule out CAD above a 95% NPV. As you can see here, the NPA version 2 maintains the NPV over 95% at both the 5% and the 15% clinical likelihood thresholds. In contrast to other scores, especially highlighting here the RFCL score recommended in ESC 2024, who only can show the NPV over 95% for the 5% threshold and not for the 15% threshold. And this is exactly what we see here now. So the Cardio Explorer generates the highest share of immediate rule out with 67.5% in the low prevalence cohort, whereas the ESC clinical likelihood tool, the RFCL, predominantly assigned patients to further diagnostic as all the other previously recommended scores by ESC. And this demonstrates a more efficient triage and a reduced need for additional testing with Cardio Explorer. And it also shows that the Cardio Explorer is able to convert the high negative predictive value into actually real-world rule-out, and that with that, unnecessary diagnostics could be avoided if Cardio Explorer would be implemented as the clinical likelihood tool right at the initial assessment. So with bringing the Cardio Explorer, implementing in the initial assessment for the clinical likelihood calculations, we would expect to exclude double the amount of patients right at the beginning in comparison to the RFCL, which would lead to less unnecessary diagnostic, while at the same time having a very high certainty here. This, of course, also means potential for cost savings and better resource allocation, and this is currently evaluated in a study in collaboration with the AOK, a big health insurance in Germany, and is expected to prove that we can actually avoid unnecessary diagnosis and decreasing costs in the health system, and would then also be implemented. So far, we've only focused on patients who are actually seen in the process, patients with a suspected CAD. But we also do have a high percentage of patients who are not even covered by the system. They're asymptomatic or atypical. They don't show up at a GP's practice or at the cardiologist. And especially scores like the RFCL have a very high weight on the symptom. And symptom-based clinical likelihood calculations, they misdiagnose such patients and underestimate the clinical likelihood in asymptomatic and atypical patients. So also here, the Cardio Explorer could be used and could be efficient as a screening tool with having 32 different parameters in there. The focus is not on the symptom, and it can also take out the gender bias, which is also proven with a specific certificate we've achieved with having equally women represented in our clinical trials than men. Alexander already mentioned there's also version 3 that has been developed but has not been validated externally yet. And as on the poster, you can find in the poster area down there, you can see a first performance evaluation we did on the MPA version 3, which looks very promising. What we also did here is evaluating how Cardio Explorer would perform as a screening tool, while keeping the false positive rate extremely low. MPA version 3 still showed extremely promising performance data here, which also underlies the potential of implementing successful MPA version 3 as a screening tool and improving patient care therewith while avoiding missed cases right at the beginning of the diagnostic process. Yeah, thank you so much for your attention. We are open for questions, and we would also really like to get in touch with you to collaborate with that amazing community in order to understand even better how that promising data and promising tool should be best implemented in order to make the CAD diagnostic process more efficient and improve the patient care. Thank you so much.